Our next speaker is Dr. Mehul Damani, sir. Dr. Mehul Damani, sir, was ex-honorary assistant professor at VS Hospital. He has won AOFOG Young Gynec Award in 2005. Since 25 years in fertility gynec practice, and he has a Foxy recognized training center also. Sir is going to talk on ideal ultrasound monitoring of endometrium and follicles. Dr. Mehul Damani, sir.
Good morning. At the outset, I would like to say big thank you to the Bhuj OBGYN Society, Dr. Puneet, Dr. Bhavik, and all office bearers for working hard to make this workshop very successful. Gujarat Chapter ISAR, Dynamic President Dr. RG, Jitu, all are always with you and all other societies, and in future myself is also with all of you. Yesterday we were lucky to visit Road to Heaven. It is near Dholavira. So in fertility practice there must be some road to success. So sonography is one of the very basic thing to learn and practice and implement. So Dr. Babisi has elaborated in her lecture of thin endometrium about the endometrium evaluation and sonography role. So here my task is to give you highlight how ideally you can evaluate the endometrium and follicle by ultrasonography, by using a color Doppler methodology to optimize or to increase the result in not only in IVF, but day-to-day infertility practice and even IUI cycle and all that thing. So here I will give you a few highlights about the endometrium and follicle management. So we all know the uterus should be evaluated by ultrasonography for its site, size, motility, texture of the myometrium. You can detect fibroid and adenomyosis on the very first ultrasonography. Then you can see uniformity in the endometrium. You can detect the polyp and synechia and optimal use of sonohysterography when needed. And you can evaluate cervix and cervical canal very well. Likewise, in ovary, site, size, shape, pattern, and motility. Each word is important. Ovarian volume, interfollicle count, and various abnormalities of the ovaries you can detect by ultrasonography. And you can evaluate the tube and adnexa very well. So evaluation of uterus, all we know about this measurement, length should be measured into the sagittal plane correctly, and when it is a anteverted or retroverted, then you have to measure both the things separately, cervix and the uterine part. Most important thing is the evaluation of the endometrium. Most of the time, I visited so many societies and taken lectures in so many places. When I ask, what is the most important thing when you do follicular study? Say, sir, 20 mm size ho jai, you have to give rupture injection, either HCG or whatever. So people usually forget the endometrium. So endometrium is the site when the embryo is implanted. It is a very dynamic organ, all we know, the physiology. Endometrium is a receptor for the ovarian hormones, and it develops with the response of the ovarian hormones of estrogen and progesterone. And various grading and scoring systems are available. Particularly here, I'm going to elaborate is a uterine biophysical profile. right? We all know fetal biophysical profile. We assess the amniotic fluid and fetal movement and everything for the fetal well-being. Here, it is a uterine biophysical profile, how your uterus is healthy and welcoming for the coming embryo. So, it was laid way back by Appelbaum, and he laid many criterias regarding endometrial thickness, regarding the endometrial layering, regarding the endometrium motion, what we traditionally called as a peristalsis. And he given a scoring system to each of these. Say, for example, for the thickness, he has given certain score from 0 to 1, and for layering, again 0 to 3, then for motion, then myometrial echogenicity, then the uterine artery Doppler flow. That is very important because it is a simple understanding that if uterus is not getting enough blood when endometrium is receiving the embryo, then it is definitely not going to implant. So uterine artery PI, endometrial blood flow going into the various zones of the endometrium given a special score, and myometrial blood flow. So this is the rough outline of the Appelbaum uterine scoring system or uterine biophysical profile. So starting from the point 1, what is the thickness of the endometrium? How will you measure the thickness of the endometrium? Some people are not correctly measuring. It should be measured from the outside of the basal layer of one endometrium side to opposite side outside basal layer. So that is the correct measurement of this endometrial thickness. So this is, can we have a pointer? Pointer. So this is the picture showing the correct measurement of the કયું ચાલે છે પેલા anyway, so thickness we should measure from the outside of the one to outside of the other. And we know that the endometrium grows at the rate of 0.5 mm per day into the proliferative phase. And in the secretory phase, it grows at the rate of the 0.1 mm per day. So, roughly, if you measure the endometrium, it coincides with the menstrual day in the natural cycle. For example, if it is a 6th day of the period, it should be around 6 mm. If it is a 8th day of the period, it should be around 8 mm and likewise. So by just looking at the endometrium, you can decide the day of the menstrual cycle, whether it is naturally developing or not. Most important thing I see in whole this scoring system is a layering. So what is layering? Layering is a different echogenicity into the endometrium. And how you define the echogenicity? You should compare with the surrounding myometrium. You look at the myometrium and look at the endometrium. If your endometrium particularly isoechoic, hyperechoic or hypoechoic, so that defines the layering in the endometrium. And Smith has given the grading system near the ovulation time. So grade A is a just post-ovulatory bright endometrium. It is a good secretory changes into the endometrium. Grade B, it is reflectivity similar to the myometrium. That is considered as a grade B. Grade C is a reduced reflectivity. I am talking about the just post-ovulatory endometrium, right? So if it is a hypo, then it is not a good grade C, and grade D is a absent echos. So if you notice in this video, you can see beautiful layering in the endometrium. I don't know whether this light is affecting you or not. But you can see this is the basal layer, this is the proliferative layer, and this is the central cavity, opposite side of proliferative and opposite side of basal. So we have to compare with the surrounding biometrium. So this is the triple layer typical endometrium what we notice. So when you look at the endometrium, just menstrual, it should be thin, bright, echogenic light. In the early proliferative phase, you can see the typical triple layer endometrium. You can see distinct basal layer, hypoechoic proliferative layer. Cavity is again bright echogenic, opposite side proliferative, opposite side basal layer. So this is a typical 3-layer endometrium into the proliferative phase. If it is not, you should think of it. And this is the near ovulation. So gradually the echogenicity into the proliferative layer is increasing and matching with the myometrium. So this is isoechoic and this is a typical post-ovulatory hyperechoic endometrium. And gradually the layers of the basal layer and proliferative layer merge. So whole endometrium is hyperechoic and it is again compared to the surrounding myometrium. Right? So these are typical 4 endometrium varieties. Again, you look at the endometrium and you can see that which phase of the menstrual cycle is this lady. Right? So this should be the ideal endometrium development. Another point is a endometrial peristalsis or the motion of the endometrium. If you carefully see the video, you can notice the peristalsis. I do not know whether you are appreciating or not, but you can see the movement into the endometrium. Like ureteric peristalsis, you can see the endometrial peristalsis. It is said that if you wait for just 2 minutes, you just hold your probe, TVS probe, watch silently for a 2 minute, you can observe 3 peristalsis in a 2 minute. It is not a long period of 10 minutes or 15 minutes you should wait. It is just 2 minutes. So you can see the beautiful peristalsis. Then it is a healthy endometrium. Another point is a uterine artery PI. It is very easy to take uterine artery PI. You have to take your TVS probe just on the side of the uterus and in the cervical isthmic region. You can easily detect the uterine artery. Switch on the power pulse wave mode and you can see the uterine artery waveform. And now I think almost all machines have a automated measurement. They can calculate for you PI, RI values and PSV values. So it is very easy to do. So uterine artery PI, if it is mentioned in many research paper, if uterine artery PI is more than 3 on the day of ovulation, it is usually not going to have a result or implantation. So many of the centers have criteria that they will cancel the cycle or postpone the cycle if uterine artery PI is more than 3. So I'm skipping this few detailed slide about uterine artery PI and RI, but this is the picture of uterine artery PI. You can beautifully get this waveform and automated calculation. They will calculate for you all these RI, PI and SD value and you can take uterine artery PI less than 1 minute time. So why I'm mentioning these minutes? Because when I take a lecture about all these things, sir, this is very time consuming. We have a very busy OPD. We cannot give follicular study half an hour. But believe me, if you routinely do all this practice every day, it will take less than 15 minutes time for evaluating all these values of endometrium as well as follicle. So it is not a time consuming, but it is highly result giving. So this is the apple bump scoring summary, and this is the zonal blood flow. You can beautifully see in this picture. This is the very few blood vessels. This is the basal layer blood vessel. These are the few blood vessels going into the zone 2, that is the proliferative endometrium. And here multiple vessels entering into the proliferative layer and few touching to the cavity. So that is known as the zone 3 blood vessels. People are measuring subendometrial vessel RI and PI value also, and it is said that it should be less than 0.05. Then it is good near the ovulation. So this is the myometrial flow. You can assess the whether your myometrium is healthy and functioning and getting good blood supply or not. So this is the summary. So at least your endometrial thickness should be more than 7. Five-lined appearance of the endometrium, blood flow within zone 3, myometrial contraction should be there like a peristalsis movement, uterine artery PI should be less than 3, homogeneous myometrial echogenicity and myometrial blood flow should be seen. So at least you should evaluate uh, uterine biophysical profile like this, and then you will have a very good result in your follicular study or IUI cycle or IVF cycle, whatever you are doing. There are now coming papers for 3D power Doppler and 4D USG also, but I'm not going to cover this aspect right now, and I'm giving you few highlight about the ovaries. All we know, we have to start with the ovarian follicle monitoring right from the day 2, day 3, and we can detect all type of ovaries and enteral follicle count, and we can rule out the corpus luteum cyst and all that thing. And enteral follicle count we know, and this is the characteristic of the good follicle. It should be well rounded. It has a smooth margin. It is a clear hypoechoic appearance, and mature follicle found usually on the 14th day, and you can detect 2-3 days earlier in gonadotrophin cycles. And dominant follicle has a linear daily diameter growth of 2 to 3 mm per day, and that the moment of the ovulation, diameter of the dominant follicle is 18 to 27 mm. Here again, I want to highlight this range. Traditionally, it has been fitted in our mind that 20 mm you should be panic, you should give rupture, injection, or otherwise what not going to happen. But every cycle, every follicle has a different threshold, right? So 20 mm size, do not panic. Evaluate the uterus, evaluate the endometrium. If it is matching, then definitely go for the trigger injection. But at the 20 mm size, your endometrium is only 6 mm. You definitely have to wait for 22 mm, 24 mm, 25 mm. Don't worry. Wait for the endometrium. When the endometrium is ready and follicle is 25 mm or more, don't worry, it will going to give result, right? So here the message I am going to give about the size of the follicle. What are the signs of the maturity? As I mentioned, size, then double folding of the follicle. Most of the time you can see when the follicle is mature, you can see outer line just beyond the follicle. It is known as a double folding of the follicle. When follicle is ready and going to get rupture, you can see the little separation of that the follicular wall. So, and second important thing is a vascularity. Here is the double folding of the follicle. You can see two distinct line on the follicular wall and the surrounding ovarian. And here you can see the vascularity of the follicle. It should be said that it should be more than 70% of the surrounding follicle. Sometimes, rarely you can see the cumulus. This is the picture of the cumulus. And signs of the ovulation, all we know, how we can detect the ovulation. Interesting thing here I want to put here is a corpus luteum is healthy or not. When you have a healthy corpus luteum, you will have a ring of fire appearance, and again your RI value drop to less than 0.05. I have a summary of all this color Doppler thing with me. If anybody wants, just give me a message. I will WhatsApp them. And at the end, I'm not going to highlight about now abnormalities and all that. I'm giving you strong message that invest some time in learning this color Doppler methodology, and it will definitely help to have a more success in your fertility practice. Thank you very much.
Thank you so much, sir, for this wonderful session. I think we'll keep the question answer session in the lunch hour. And to move on to the third session, I would like to invite Dr. Nirmala ma'am and her team to take over the mic. Thank you.